Fantastic. This is so much fun to be back. And I got two of my newly favorite people. I think they're going to be regular guests on the show because they represent two things that we got to talk about. One is men's health, Dr. Sean Tierney, urologist, and Liam Westgate is new to us, but a topic that's kind of near and dear to my heart, which is addiction medicine. We will get into that in some depth, but man, there's a major problem with drug use in this state. It affects my practice. I'm sure, Sean, you see this all the time, and we need some answers. We need to educate the people, Liam. So you're going to be on the hot seat today. I am interested in so far that people are calling in. They're even calling in before the show has started. And so I love that. I think this conversation between us doctors and you patients is important to continue. So, Jerry, do we have a caller that's here that can give us a question?
Yes, we do. Vina is on the line. Vina, go ahead with your question.
All right.
Well, I've been Rio Rancho, and there's such a shortage of dermatologists. I have to drive into Albuquerque and get one that's not a press doctor, and I can only see the medical doctor once every 3 years. The rest of the time, I have to see a nurse practitioner. Any advice for me, please?
Oh, that is interesting. So they limit you to every 3 years. Did they actually tell you that?
Hello?
Hi, can you hear me, Verna?
Oh, now I can.
Oh, so do they really limit you to every 3 years? They told you that?
Yes, to see the medical doctor.
Interesting.
And she's down Alameda, down by the Harley Davidson.
I gotcha. Do you mind sharing? Can you share with us what kind of dermatologic problems you're having?
Yes, I have lesions on my legs from the long time that I had cellulitis.
Oh, so
I'm not getting relief from my podiatrist.
I got you. So it was a prior infection. Have you had to have surgery?
No, and I'm a little too old. I don't think they'd do it for a person in their mid-80s.
I don't know. You sound like you're still pretty with it and active, so we should stay on top of it. All right, I'll address your question here on the air, and then we'll kind of take it from there. So what's happening is that it's expensive to see the doctors for chronic problems, and so we can limit a little bit the overhead and the expenses by having the patient see extenders, so physician assistants, nurse practitioners, that kind of thing. It's not necessarily a bad thing. I know someone of Verna's age probably traditionally expects to see the doctor, but the landscape has certainly changed. So I want to support our PAs and nurse practitioners. They do a great job, and they are very tightly coordinated with us surgeons and doctors. Sean, do you use folks in your clinic to extend?
Oh yeah, we wouldn't be able to survive if we didn't. I think the problem that she's running into is she's trying to see a specialty that does office procedures.
Right.
And so any specialty that does office procedures will use extenders to keep the physician doing the procedures, because the extenders can't do the procedures for the most part. And so you want the physician to do the procedures, and to maximize the amount of procedures that can get done of all the patients that need procedures, you got to keep the physician doing the procedures, so the patients that don't need the procedures end up seeing or being filtered out to the PAs and nurse practitioners.
Yeah, I think, Verna, you're not the only one that's frustrated with the situation. There simply aren't enough doctors and surgeons to go around. And so I don't know if you're aware of this whole thing, but they're actually grooming nurse practitioners and starting to credential them to be rural providers, almost like doctors. And there's not much we can do other than support them and kind of think about novel ways to get healthcare to folks like you, even though we have shortages. So I hope that answers your question. We care about you. We're overwhelmed, I would say. All right, so I'm going to switch gears a little bit. Liam, can you, I have some really important questions for you, but I'm going to start with something really simple. What is addiction and what is an addict? And maybe thirdly, why do we have so much of it in Albuquerque?
So those are really, really ambitious questions. And so maybe in responding, we can talk about just different ways that we not only think about addiction, but how we can talk about addiction, right?
Okay.
One thing I want to sort of distinguish is that there are many folks, for instance, that might have like chronic pain issues that might be relying upon certain kinds of controlled medication, but that doesn't necessarily like beget problematic use. When I think
Right.
about addiction, I think about the idea of using a particular substance, which could include a range of substances, whether it's alcohol or maybe opioids or maybe other illicit substances that we
Right.
often hear a lot about. But when we think about addiction, it's a kind of use that ends up causing real consequences for folks. And oftentimes, as someone who's worked in addiction medicine for many, many years, somebody who might be struggling with addiction, it doesn't necessarily mean that they don't know that they're struggling with a problem. It
Mhm.
means that there's something that's also happening biologically, physiologically, because of use of that substance that really results in folks not having control of that. Right.
Right.
So when we think about addiction, think about it as use that creates problems, maybe in employment,
Okay.
interpersonal relationships, parenting relationships,
Right.
other really important areas of a person's life. So in thinking about that kind of thing, and maybe I'll think about question 2 and question 3. together.
Just off
Yeah.
the top of my head, do you happen to have any statistics in your head about like the rate of heroin addiction, for example, in Albuquerque or New Mexico? What do the numbers look like? You can even just general
Yeah.
terms.
I would actually, maybe in lieu of talking about rates of heroin related addiction, I'd actually point to something like alcoholism,
Okay.
just because that statistic's really compelling.
And it crosses all
crosses all
socioeconomic.
socioeconomic
Everybody knows
statuses.
someone who's got
Correct.
that problem in the
And
state. Yeah.
when you look at the state-based statistics for things like alcoholism has actually been one of the major instigators for death and premature mortality.
Mhm.
It's one of the top 10 reasons for that in New Mexico, probably for upwards of the last 30 years.
Wow.
Right. So oftentimes when we talk about addiction, I think that it's really important to think about the ranges of substances that folks might use. The other reason I mentioned that is in treatment facilities, a lot of times folks will go to treatment, let's say for heroin addiction, but they might have a parallel issue with
Right.
alcoholism.
Right.
Right. So it's not uncommon when we look at addiction that folks may not be using a single substance, but there might be a range of different substances that folks use.
I got you.
Um,
It's funny. I mean, I deal with a lot of folks that have these kind of problems, and my big issue is that they tend to use dirty needles, and the bacteria gets in the bloodstream and eats their
Mhm.
spine away, and then I have to fix that. And they're gigantic surgeries. I just did one
Yeah.
this week, 9-hour reconstructive spine surgery, and mental health, addiction, alcoholism, these things are all sort of so tightly wound together in these patients. It's just
Yes.
a disastrous cycle. I mean, and you drive through the city, you see folks on every corner. Um, is there hope? Well, it seems overwhelming, especially when you know a lot of
Mhm.
these patients like I do.
I think that's a really good question. A lot of times when folks, have different associations for things like you just shared, right? What are the public examples that we see of folks maybe who are struggling with houselessness in addition to things like addiction? One of the things, though, that I find really, really fascinating in the world of studying addiction is that there's actually a really sizable proportion of folks that have had access to early intervention, maybe who had problematic use. They had a meaningful conversation with their primary care provider. And that was actually persuasive in a way to link them to some of the preventative care measures, right? That either dissuaded them from problematic use. And I think the other thing we don't talk about enough specific to Albuquerque and New Mexico is there is a very robust recovery community.
Oh, really?
And so one of the things that I've been really, really impressed with since I've relocated here from Baltimore City, I'm originally from Baltimore City. We've had a lot of parallel issues with a lot of
Sure.
the things that you're talking about. But getting plugged into the amount of mutual aid that's happening in the recovery community. And that's happening for two things. One, because that mutual aid in that recovery community, it's a way for folks to give back
Okay.
and to help people who have that shared lived experience. And as you kind of mentioned with the previous caller, there's a lot of access challenges, right?
Right.
And so when you ask the question about why is it so complicated, there's not one reason, right? We could talk about trauma. We could talk about generational trauma. We could talk about, access to care. But when you put that connection between, long-term challenges around mental health as they then flow into addiction-related challenges, you can also have a really significant proportion of folks that are ready to get care and where do they go?
Okay.
Right.
All right. I'm going to stop you there because as fascinating as that is, we have like 10 more layers to go on that.
Yeah.
Because I want to know whether, I asked you about hope. I want to know
Mhm.
whether things can be changed. And
Yeah.
a lot of these folks, they just seem hopeless. And then we're going to get back to talking to Sean
Mhm.
Tierney. He and Liam are both Irish, and we're going to need to understand. Maybe we can talk about the origins of alcoholism. Is it genetic? Did it come from the green Emerald Island? I mean, I don't know.
You know what they say? They say God invented whiskey to prevent the Irish from taking over the world.
It left them confused. All right, real good. I think we're coming up on a short break here, and Jerry's going to guide us through that. But I love this. Thank you guys for both being here. We're going to have some good conversation.
And we'll continue with 96.3 News Radio KKOB.
All right, we are back, and we're talking with Dr. Sean Tierney and Liam Westgate. Sean, let's maybe move to you. You're kind of like my my right hand co-host in doctoring. Let's make the transition, though. I am curious whether things like drug abuse has affected men's health. I know there's probably a link with erectile dysfunction, and I know that, but I deal with patients that get infections in serious parts of their body. So we talking bladder issues or penile issues, or how bad can life be for someone who's addicted to injectable drugs, for example?
Well, I mean, from a urology standpoint, mostly what we see is people are using before surgery.
Oh, really?
And that makes an issue with anesthesia.
Right. You can't get enough meds in them.
Yeah, especially with meth use within 24 hours anesthesia, it creates just nightmares for our anesthesia colleagues. The main drug abuse that we see in urology is we're seeing a rash of end-stage bladders. And what an end-stage bladder is, basically it's a contracted bladder that won't expand, causes severe frequency, urgency, and those type of symptoms. And that happens as a result of what we're seeing from a drug use standpoint. That happens as a result of ketamine abuse.
Oh, really? I wouldn't think of ketamine as a street drug. Is that out there now? Maybe Liam can answer that question.
I wouldn't be able to comment on the specificity of that.
Mhm.
I do think by virtue of our peer support specialist program, we sometimes hear from community before it shows up in our care centers about supply changes, landscape changes, those kinds of things. I think I could speculate ketamine is probably becoming more normalized, right?
Really?
And different treatment modalities for things like depression, PTSD, those kinds of things.
Yeah. So for the audience who may not know, there's ketamine clinics, and it's
Mhm.
really started out for veterans and
Correct.
PTSD, and it's actually very effective in kind of mood resetting and fearfulness
Mhm.
resetting, and people get treatments fairly frequently. But it is also used as a general anesthetic, and we do use it sometimes in the operating room to put patients to sleep. I think that would probably be a hard thing to get a hold of, but man, I mean, fentanyl ended up on the street, and that was
Mhm.
always an operative drug.
Mhm.
So in urology these days, new technology, what are we looking at in terms of the future?
Well, we got one right now. We brought in a new type of focal therapy for prostate cancer in New Mexico. It's called NanoKnife. Basically, what it is the abbreviation is IRE, but it's irreversible electroporation. And what it does is it creates an electric field around the cancer cells, opens their cell gates, and keeps them open.
Makes them vulnerable.
So they can't close, and they die. And we used to use cryosurgery as a method of focal therapy.
And what is cryotherapy?
Just basically putting needles in and freezing, taking the area down to about minus 40 degrees centigrade.
Chile.
And that would freeze the tissue. But now with this new therapy, creating the electrical field, we have less complications.
So it doesn't burn it per se.
No.
Does it make it sort of vulnerable to chemotherapy, or is it
Well,
just?
that's how it was originally used.
Yeah, that's how I can remember.
It was used as reversible, where you
Oh, I see.
you would create the electrical field around the tumor in a reversible status. So the lower electrical potentials create a reversible situation, give the patient chemo, then release the electrical field. And since the gates were all open, the chemo would preferentially penetrate where the tumor was. What we do is we irreversibly open those gates so anything in that electrical field dies.
So is that like a higher voltage or something?
Yeah.
Okay.
Slightly. And if you go too high, then you get the thermal
okay.
changes within, and you try to stay in between that range.
So why is this more effective? Better long-term outcomes? Is a wider distribution of therapy? Like, can you quantify it? Why should I get it done?
Well, first, to get it done, you have to understand that you have to have a certain type of volume of tumor. The smaller the tumor, the better.
Okay.
And so we run into this issue with focal therapy of, do we watch it? Do you treat it? And there's that seesaw. The second aspect of focal therapy is that it's a paradigm shift, and the patient has to be aware of that. With focal therapy, the rest of the prostate is still healthy. So there's less side effects, which is great, but that means the rest of the prostate can still get cancer down the line. Whereas if you treat the whole gland with either radiation or taking it out, then any type of rise in the PSA is a concern for the cancers coming back.
I got you.
The PSA is going to rise in a patient who's had focal therapy because the healthy tissue is going to continue to grow. And then it becomes an issue of how do you determine if that's a recurrence of the cancer or if it's just normal changes. And so the patient has to be ready for multiple investigations, whether that be biopsy or an MRI down the line.
All right. Well, let me ask you the difficult question, because we had Dr. Tierney on before, and there's a lot of male listeners, viewers, I guess now too, because we're doing live streaming. And I think it's time for us to have the conversation about erectile dysfunction and these different options for prostate cancer. Is one therapy more protective than another for a person's sex life?
Focal therapy traditionally has been. The problem with cryosurgery is it was an ablative technique.
Just kind of destroyed everything?
It did. And if you got too close to the nerves, you destroyed the nerve.
Okay.
Whereas this procedure, because it opens the gates irreversibly, if it does affect the nerves, they regenerate because the cells don't die. The cell bodies are far distant from the prostate, and the axons run underneath the prostate. That's what controls erectile function. So if they're affected at all, usually it's the Schwann cells, those fat-covered cells that
protect the nerves,
nerve, then help the transport.
Now you're talking my language.
I know. and so they regenerate. And so what we'll see with this procedure is if there's a drop-off in erectile dysfunction at all, it's usually reversible, and in about 6 months, the patient's return to function.
Oh, I think that's really good. Is it fair to say in general that the new technology, as you guys are developing it, you're thinking about that question? We're trying to preserve erectile function.
Oh, always. And we thought there was going to be a major change when we went to the robotic surgery, because we now have 10x, basically a magnifier right there where we're dissecting the nerves away.
So you can protect them, yeah?
Correct.
Yeah. Man, that's important stuff. The population is aging. Men are living longer. Typically they lived, 10 years less than women, I think. And now the gap is closing. And quality of life. I'm doing surgery on people in their 90s because they're still playing pickleball. and clearly they still want to have sex.
I have 80-some-year-old men come into my office all the time, probably at least every 2 weeks, with complaints of erectile dysfunction, saying, "Hey, got to fix it."
And we still want a lifestyle, which is great. You can't be ageist in our world. All right. Well, anyway, we'll come back to that. We want to talk more about the nano knife and where can a person, should they ask for this? Is it good to have patients that are educated?
Oh, yeah. So there's multiple ways to treat prostate cancer. And unfortunately, a lot of urology practices don't offer all of them.
Right.
And so that's where it comes in. So the main difference is, are you a candidate for focal therapy or not? If you are, then right now, in my opinion, I think the best focal therapy is the nano knife.
Mainly at Rust, or where are these performed?
Right now we're downtown.
Oh, you're downtown. Okay.
So Dr. Bandon, Alex Bandon, and myself are doing it downtown. Dr. Aman, sorry, Gazim Amani, my other partner,
Uh-huh.
is at Rust, and we're working on getting another generator to get him going up there.
All right. So is this thing like Star Wars lightsaber looking thing? Like, what does it look like?
No, it's actually kind of boring.
No.
Yeah, it looks a little bit like a something you see in a car mechanic's office.
It's like a
little
box
wires
with-
coming
yeah.
out of it, stuff like that. Yeah.
I was picturing, Obi-Wan Kenobi doing prostate surgery or something. Nano knife.
Yeah, no. So the way you apply it is through needles,
Oh, okay.
like we did with the cryosurgery. But now instead of sending liquid nitrogen through the needle, we're creating an electrical field with the needles.
There's some really interesting things in brain surgery that are similar. We use some drugs to open up the pores of the cancer cells selectively and then get the chemo to attack that. There's areas of the brain that are protected by something called blood-brain barrier, which I think is probably even more difficult to deal with than what happens in prostate cancer because it's a multi-level, multi-layered sort of problem.
We deal with a similar barrier.
Yeah.
The body does not like chemicals getting into the brain or
Or the
or
prostate.
the reproductive tract.
I can remember we did interesting things when I was in a resident. We would inject various viruses that could cross the blood-brain barrier. And so you got to be creative about this. You can't just come up with a chemotherapy or a treatment and not deal with the fact that the body has its own defenses you have to overcome. So this sounds like a brilliant new development that you guys have brought online. All right. So I think I'm going to switch back to Liam and kind of talk a little bit more about what's available if you are addicted. We could have a very broad discussion about different types of addiction. One thing that comes to mind is there's gambling addiction. Do you deal with all that too? Is that all sort of in the mix, or is it really substance abuse?
I think, excuse me, I think gambling addiction is actually fairly underappreciated.
Okay.
Right. Prior to joining Presbyterian, I've worked with folks with gambling addictions and those kinds of things. And it's been interesting to even see a conversation around that over the last couple of years.
Okay.
Again, especially when we're in an environment where you're seeing more normalization of access to casinos and those kinds of things.
Right.
And all that sort of thing. But for the program that I run, we have a peer support specialist program.
Yeah, that's the thing I really want to hear about. Like, this kind of blows my. I'm so proud of Presbyterian for doing
huge.
this.
It's huge. When you think about the peer support specialist program, it is a program that's available right now at actually within the next month or so at all of our hospitals.
So is it true that if I'm in trouble and I'm a known addict, but I'm recovering, I call you, or how does it work?
The way that it works is that we have peer support specialists embedded in our emergency departments.
Okay.
So sort of the point of entry, so to speak, is if we have somebody that comes to an emergency department, there's a universal screening that we do for all of our patients. So it's not just targeting one group, but it's really recognizing that, again, there's a range of issues that folks might present with. And it's what's called an SBIRT screening, which is a screening, brief intervention, referral to treatment. There's a list of questions that folks might ask about, different challenges that folks might have. And if there is somebody that has a positive SBIRT screening, I'm going to give you the very nuts and bolts of it, or overview of it. If there's a positive screening, then they get a referral to one of our peer support specialists that will either meet with them on the spot in the ER or do a follow-up call or engage them in some form or fashion. That intervention is going live again in our emergency departments as well as our urgent care centers.
Okay. So what I was kind of excited about was this idea that the folks that you're recruiting to be peer specialists. Tell us about how
that's a great question.
is.
So the peer support specialists are people who are in recovery. That's sort of like
addicts helping addicts.
Right.
Okay.
And it's a role that's really based on a shared lived experience.
Yeah.
And the idea that we've walked in the same shoes, we've had the same experience. And what we find routinely is peers can have conversations with patients that providers can't.
Right.
Right. It's a different way of engaging. It's a different way of talking. It's a different way of relationship formation. And I would also offer there's something else that we've actually found in our emergency departments, which is not only has this resulted in better patient outcomes and better patient engagement, but we've also found that for providers that now get to work side by side with our peers, it also increases their capacity, right?
Got it.
So that they can focus on what they need to focus on, so that our peers can have the conversations that we need to have with our patients. And sometimes it can also reduce the stress, right?
So,
That folks might have
let
as
me
well.
ask you this real quick. Is it hard to get addicts to reform enough that they want to participate in and be mentors? Or do you have people lined up or?
We partner with local community programs that really work at a community level to recruit peers to do sort of pre-employment training. But the way that our team is set up, we also have two peer supervisors that don't just do the ops piece, but they provide that mentorship,
Yeah.
right? Because if you have somebody who has had, whether it's past experience in carceral settings or just different things that come up,
Mhm.
right? Different unique challenges, we have those peer support supervisors that can really model, right, how you can manage the stress and the difficulties that come up, and also different ways that we can problem solve with patients, right?
I think the story that I heard, which I don't know if maybe it was atypical, but
Sure.
a gentleman went to a bar. He had a long history of using drugs and was very tempted at that time and made a phone call to one of these peer support
Yeah.
folks. And the guy showed up and picked him up in his car and took him away from the environment and basically helped save him from himself.
I will tell you a thing that happened recently, within the last couple of weeks, which was kind of amazing, which is we had one peer that had 2 patient referrals that were made. She called one of the patients. They didn't respond. She called the other patient. It turned out the 2 patients were married.
Oh boy.
And she was able to engage with both and then refer them both to the same recovery program so they could
Gotcha.
heal together, which was pretty. I mean, so when we hear these one-off stories, I actually get to hear those stories multiple times a month, right? In terms of what they're doing. But that one really,
Right.
that was like also really reflective that, addiction is not just an individual thing, it's a family thing, right?
I would love to hear from anybody in the audience who wants to chat about and is willing to share either an addiction story, alcoholism story, or anything that's on their mind. We have a super specialist here in Liam. He runs a very important program. And, we haven't had, that kind of conversation with the public about what they've been struggling with. So if anybody wants to call in, I think both Liam and I would be happy to
Definitely.
hear your story and maybe respond. I think we're getting close to taking a break, Jerry.
Yeah, I just wanted to give out the text or phone number.
Yeah.
You can text or call 505-243-3333. Dr. Liam Westgate. We're also joined with Dr. Sean Turney.
I just got a degree.
Thanks.
Thanks.
I think your history is
did
that,
I give you a
no, that's okay. His
promotion?
history is that I think he's worked his way up and he started out as a social worker. I think.
I'm a
Oh.
career social worker for like 20
But,
years.
I want to hear that
Yeah.
story.
Now he's
That's
a big
cool.
time director. So
Yeah,
Okay.
but,
hanging out with these guys.
Well, Liam Westgate, and of course our host, Dr. Greg Scher.
that's me.
The doctor is it. 96.3 News Radio, KKOB.
All right, we are back in. The doctor is in. Dr. Gregory Scher. I'm your host. I'm here with two really important people, Dr. Sean Tierney and Liam Westgate. We're talking about men's health and also about addiction and addiction medicine and interventions. Before the break, we were kind of chatting about this new program. And what's the name of it? Peer-to-peer? Or?
Peer support specialist
support
program.
specialist.
Yeah. Or sometimes we say interchangeably the SBIRT program. Right. Yeah.
I am still curious if anybody in the audience wants to call in and kind of share that. Is there a lot of stigma around talking? How do you get people to engage you or admit to it, I guess?
Yeah. I mean, well, you mentioned stigma. And one thing I think that comes up again and again is the number one barrier to treatment is stigma.
Okay.
Like even in situations where folks have access to resources, proper insurance, funds, whatever, stigma is a huge, huge barrier. So it's easy to say that the number one way to get people to talk is to remove stigma, right? So things that our peers are trained in are things like harm reduction, right?
Okay.
Which means a lot of different things, and happy to talk more about that. We also train all of our staff on things like trauma-informed care. So how to ask questions in a way that is more oriented to help versus accusations, right?
Right.
So I think those kinds of things. And then I think the benefit of having peers is you have a person that's leading with, this is my story. Right. And sometimes for people who are like not ready to talk or to engage or those kinds of things, you kind of need a door to open the conversation. Right. And for a lot of folks that are seeking treatment, they don't often get to talk to people that have had that thing in common. Right. And if you're somebody who's experiencing stigma or really more specifically ostracism, right, being cut off from community, cut off from people, that community of support is so important. But the idea of meeting somebody who's leading with me too can really change the conversation, right?
Gotcha.
And also punctuating those conversations with, I'm here when you're ready, right? So like, I think the magic that peers do is they can talk about things in a different way. And they also understand because of their own lived experience that it's a process and that it often takes many, many tries to kind of get onto the next step.
It sounds like that's really wonderful because I think from a physician or a provider standpoint, the problem is, can you break through to that point where they admit, yeah, I need help? Because there's a barrier that oftentimes we can't get through, that the peer may be able to get through to the point where, hey, even if you're not ready for help, when you are, call me because this is my story. This is how my life changed. We can do it for you.
Yeah. And one of the things, we have a really amazing peer supports supervisor, Donald Hume, who's like really a local community leader in this space as well. And one of the things that I've really learned from him about the idea of recovery is that recovery is not, did you go to treatment, right? Because you can go to treatment and that doesn't mean all the things that are underneath are necessarily being addressed. But he really talks about recovery as anything that somebody's doing to improve their quality of life, right? And so when you give somebody that as a goal, that can open up a wealth of things that you can do. It could be, again, going to a recovery center. It could be addressing your relationships differently. It could be, acting maybe with from a place of honesty that's really uncomfortable, right? So I've learned a lot from them about things that they know because they've also been in systems where things either worked well or didn't work well, right? So they teach us a lot also about how, especially within Presbyterian, what can we do differently, right? Yeah.
Sean, I am reminded about the idea that before Viagra came along, things like erectile dysfunction, there was this shame that was involved in it. And, probably the only person that you would ever talk to if you had that kind of problem would be a urologist. Why did it all change? Now it's like, it's accepted. I'd say we talk about it now on radio show. We talk about it in general. Like how did the shame go away from such a thing?
I don't know. Maybe just the blitz of advertising. It became
normalized.
mainstream. Yeah, it became mainstream instead of something that would come up only in a conversation with your doctor, and sometimes only if the doctor actually asked you.
Yeah,
we were treating erectile dysfunction when I was a resident. Of course, we didn't have Viagra at the time, and all we had was
implants, I guess, right?
We had some pills that were not really
very effective.
They didn't work really well. Vacuum erection devices and then injections. And that was the mainstay of treatment until Viagra just blew the doors off the whole disease process.
What wasn't the advent of that? They were working on a different type of drug, and then they found that somehow.
I don't know the history of how they found it.
I think it ended was they were looking for a cardiac drug, and Jerry's shaking his head. He knows the history, but because they use it in the ICU sometimes for pulmonary hypertension, I think, don't they?
Low dose.
They used it on my daughter in the pediatric. Actually, it was the
Oh, that's
neonatal, and it saved her life.
Yeah, Jerry's had an amazing experience. His daughter, it was congenital heart.
Yeah,
issues?
due to prematurity. She was
Yeah.
born 3 months early and just never developed the alveoli, the air sacs in her lungs. So
And-
she lived 18 years on a ventilator, and she is very
To this
mobile
day.
and plays piano and
That's amazing.
just
Yeah,
thriving.
and she's a ICU critical care success out of Presbyterian
Out
too.
of Presbyterian,
Yeah,
out
man.
of the Cura right wing in the pediatric ICU. That's room number 8, by the way.
And was she there for?
She was
Long
there.
time.
She was there for a year, 550 some odd days, the first go round, and she's probably been
Wow.
admitted probably a good dozen times.
But quality of life and
Yeah.
all due
Oh,
to
yeah.
Viagra. All right,
Oh
well,
yeah,
we're learning stuff.
short and feisty.
Today. But she doesn't have to be on it now. For the
No,
heart,
no,
does
no,
it?
no.
So it was just
No,
when she was a kid.
Yeah, when she was first born, it was backing up on the pulmonary side. So
Right.
on the lung side of the heart,
Yeah.
it was working so hard that the muscle tissue got to be 4 centimeters thick, which is normally it's, I believe, like 1.5 centimeters
Wow.
thick, the muscle itself. So it was slapping together every time the heart beat.
You know more about this than us doctors haven't lived through it.
Yeah, fortunately, after she was about 2 years old, the the heart doctor, the cardiologist said, "Yeah, she's boring now, so I don't need to see her.
That is such a
I'll,
great.
I'll see her for a couple
I
years."
I
and
love
then-
survival stories
Yeah.
like that. I mean, like I'm sure hard on you and expenses of it, but my gosh, what a great outcome. So what other urology issues, social issues do we struggle with now? Prostate cancer has become a chronic disease almost. Erectile dysfunction. What other men's health issues are out there that we worry about?
Well, I mean, the cancer gets all the news, and that's unfortunate because the big stigma issues for people, for men anywhere, erectile dysfunction and then incontinence.
I had a really interesting clinic this last week. I had a number, surprisingly, just for whatever reason, of transgender patients in both directions. So people who look like women and who are having prostate issues. Do you see this now?
Oh yeah.
And that's a unique challenge, I imagine.
It definitely throws the front desk off.
I mean, yeah, talking to a woman about her prostate issue. No, so it went the other way. I've had a patient that looked like a man, and had men's issues, calcium deficits and osteopenia and things like that, and didn't want to talk about it right away, but finally disclosed that he had a uterus. And some of those hormone therapies affect how we deal with spine surgery, for example. And so it's a complex world for us doctors out there. It's not easy for us to know what to do sometimes. You can't judge a person based on how they look. You really have to have conversations. You got to talk to them and figure out what's going on.
Yeah, one thing we're seeing a lot more of here is transgender male to female who are trying to get off some of the hormone therapies. One of the ones they use a lot is spironolactone, which has a lot of side effects.
Okay.
And
So that's usually for
suppressing
urinary.
testosterone.
Oh, I see.
And,
Okay.
and so having the testicles removed, we have patients coming in wanting orchiectomies,
Gotcha.
removal of the testicles, because
Right.
it helps them get off some of the medications that cause a lot of side effects.
So that wipes out any production of testosterone, essentially. Okay.
Almost all of it, not quite all of it, but most of it.
Does normal day-to-day urologists do that kind of surgery?
They can.
Yeah.
I don't know if they're comfortable doing it.
I remember when I was in Florida, there was a few specialty places that did the big reconstructive urology stuff to transition between a man and a woman, which is kind of amazing surgical work. Have you ever participated in that?
No, we actually had a training center in Eastern Virginia that was fairly famous for doing.
You could do a
that work.
fellowship there in,
Mhm.
in transition
Yeah,
surgery.
and it was all urethral reconstruction, transitional surgery, and things like that. Now it's mostly in the realm of the plastic surgeons.
Even the urethral stuff, even okay, they go and they handle the whole reconstruction. Boy, that is fascinating. I had a friend who went into it in Miami, and of course he drives a nicer car than I do now, because it's all cash business. But really elegant, beautiful surgery from a surgery point of view. Thinking about doing reconstruction of a whole new gender out of it, just really remarkable surgical work. All right. Trying not to be controversial anymore. So let's go back to addiction, which is obviously not controversial. So Liam, what would you want the group of listeners to hear? And I was kind of getting to this question about hope, and I see these patients come in and I fix them, and I'll tell you what I do. I usually let them heal after these gigantic reconstructive spine surgeries, and then I have kind of a heart-to-heart conversation with them. I say, look, use the dirty needle. You've been in and out of emergency rooms, methamphetamines, and the chances that you're going to end up becoming paralyzed by this the next time it happens. Of course, I do see that, but I try to do this. Let me connect with you as the surgeon and say, look, you don't want me to come back and redo this again. You're so lucky it didn't happen to you. And I'd say 10 to 15% of them. I have some great success stories out there. But it really breaks my heart to have to take them on again when they come back and they didn't change their behavior. So that's not a high number in my experience. Where how do we change that?
Well, I think a moment ago you asked the question of what changed around the conversation around erectile dysfunction. Right. And you answered messaging, right? And medication.
And branding.
And branding. And also
the companies probably wanted to have it out there.
Yeah. But when I think about things like substance use treatment and those kinds of things, I think one of the myths that I've seen as a clinician is that there's this idea that things happen sequentially. And in the world of addiction medicine, we actually have really good medications. Suboxone.
Right. Oh, can you explain what that is? Because a lot of people don't understand the combined drugs. Sure.
So I'll use less the names and just talk about sort of the theme. But medication assisted treatment is a type. It's a group of medications that a provider, sometimes a primary care physician, sometimes an addiction medicine doctor, even an emergency department.
Us surgeons use it. It's new and it's a combined drug. So maybe you want to even talk a little bit about that.
Yeah. But it's a range of medications that can be prescribed for things like alcoholism, opioid use disorder, right? Many people are probably familiar with things like methadone, right? And methadone is actually a gold standard. It's actually a very
when I was in New York, there's clinics every couple of blocks, and you'd have to go in and get your methadone.
It's often super stigmatized, but there are actually like positive effects of methadone that are probably beyond the scope of this conversation. But methadone is one of the most well-known types of treatments, right? For things like, heroin addiction and those kinds of things.
And just to interject, the object of that was to take the real high, the euphoria out of your addiction.
Correct.
And give you a medication essentially that was a bit supervised. You had to go to a clinic to do it.
Yeah.
But also managed to hold off your biological withdrawal symptoms.
Yeah.
Right.
And to that point, I mean, when you think about addiction, what does it do? It hijacks your brain, right?
Yeah.
Well,
we got to get back to that topic. I'm going to take a short break here as we only got about 9 or 10 minutes left. But of course, now we're getting into the meaty part of what I want to know.
Yeah.
So again, if anybody wants to share their story about addiction or alcoholism, I know it's not an easy thing to talk about. We promise to treat you with respect. Give us a call, but we'll continue the discussion with Dr. Tierney and also Liam Westgate. Jerry, what do we got?
Well, you, our host, Dr. Gregory Sher, and the doctor is in on 96.3 News Radio KKOB.
All right. The doctor's in. I'm your host, Dr. Gregory Scher. We're talking with Liam Westgate and Dr. Sean Tierney about lots of controversial stuff, everything from men's health to addiction medicine. So we were kind of focusing on just telling a little bit of the history about how heroin addicts used to go to methadone clinics, and now has Suboxone, this combined drug of it's sort of the same as methadone, but it has some naloxone in it, which helps prevent you from overdosing and that kind of thing. Is methadone going away in favor of those new fancy drugs?
Not necessarily.
Okay.
I think each region and each provider uses them for different reasons.
Gotcha.
Right. I mean, I've worked at on the East Coast. I worked at a hospital that had a very robust methadone program.
Right.
And it wasn't just about administering the medications, but it was also about having a community of support around that, group therapy, all those different sorts of things. One of the benefits, though, of things like Suboxone,
Yeah.
right, which you mentioned as an example, is that it can be administered in different spaces, to include even in primary care settings.
Okay.
Right. And so when I think about the benefits of increasing access to these kinds of tools, really, they're medications,
Right.
but they're also tools for clinicians,
Right.
is that if you really want to enhance a person's readiness for treatment, you have to treat the symptoms.
Yeah.
Right. And you were before the break, you were kind of describing, at a very high level, some of the ways that these medications can change things for folks. And one of which is it shifts the reward system, right, in the
Right.
brain. Right. So if we talk about things like if someone comes to an emergency department, and we have programs in our emergency departments at Presbyterian that are going to be starting to increasingly do these kinds of things. But if we have somebody who's in need of treatment and we can initiate them, on these medications as appropriately assessed with, the patient's consent and the provider, we can really enhance their motivation because their symptoms are being treated while they're being linked to care.
Got it.
Right.
I have a family member, a distant family member, but
Mhm.
who went through alcohol withdrawal recently.
Yeah.
And she ended up having, I guess, is it weekly injections of something
Mhm.
to, and how does that work?
Yeah.
Preventative.
There's, I mean, the evolution of medication in this space is really impressive, right? One of the biggest burdens we see for folks with any chronic issue is what does it mean when you have to take a pill or a medication every single day? And some of the things that we're starting to see emerge, not just recently, but especially maybe in the last, I would say 5 to 10 years even, right, are things like you're referencing which are called long-acting injectables, right?
Okay.
Where sometimes somebody might come in for an injection of a particular medication to deal with their symptoms for a week. Sometimes we've seen this also with folks with serious mental illness where they can get a monthly injection.
Okay. Well, this
And
was specific
it's
to,
huge.
I guess the concept
Mhm.
here is, we don't have to go into the science,
Sure.
but I think I understand it. If she starts drinking, she becomes violently ill, and it's sort of,
Mhm.
everything's about sort of, countering your addictive behavior kind
Yeah.
of.
Yeah. So basically that use can create new side effects for the person for sure.
So there are ways to intervene in both addiction and the behaviors that lead to it.
Correct.
And now you're also able to treat prostate cancer and erectile dysfunction. So we are so grateful, Dr. Sean Tierney and Liam Westgate, for taking us through both of those thorny issues on today's episode of The Doctor's In. Thanks for listening. We always value your phone calls. So we'll see you in 2 weeks on Saturday. And thanks again for tuning in.